Assalamu alaikum. This presentation is on disorders affecting the salivary ducts. Salivary duct disorders, including primarily obstructive salivary ducts diseases, whether these are due to stenosis of the ducts or due to stones impacting in the ducts. We shall also discuss recurrent parotitis due to duct problems, including the juvenile and the adult versions. In these two disorders, the duct system is affected by a combination of Sialectasis and also strictures, followed by salivary duct cysts and papillomas and salivary duct carcinoma, and finally the functional changes in salivary duct cells that is translated into pathological changes in the salivary electrolytes. Obstructive Sialolithiasis is the condition of mechanical obstruction to the flow of saliva through the duct system into the oral cavity, associated with stasis of the saliva and intermittent inflammatory process in the gland parenchyma. This can happen due to stones in the duct system, or also strictures, fibrous strictures narrowing in the duct system at different levels, but also due to fibromucinous plugs or foreign bodies, or sometimes anatomical variations in the duct system due to sharp angles or kinking of the duct system or congenital malformations. This obstruction to the flow of saliva will cause recurrent, painful episodes of salivary gland swelling. These episodes would usually happen around the meal time. It's called a mealtime syndrome. And from time to time, an inflammation, acute inflammation of the parenchyma of the gland can be caused by bacterial infection because of the saliva stasis, and this will give rise to fever, purulent discharge from the duct papilla, and painful swelling of the gland. The obstructive salivary duct disease is caused primarily by stones and strictures, but also by conditions like inflammation of the duct cells itself, Sialolithiasis, and things like mucus plugs or polyps or cysts or even tumors in the duct systems, plus of course compression on the ducts or kinking. The salivary duct stenosis are the second most common cause for the obstructive gland disease after salivary stones. 15 to 25% of the cases of parotid gland, and lesser frequency, 5 to 10% of obstruction of the submandibular glands, are due to strictures rather than stones or other pathologies. Even more interestingly, up to 50% of the cases in which there is an unclear recurrent gland swelling, the cause would be a stricture in the duct system, and up to 85% of all obstruction not caused by stones would be due to strictures in the ducts. Unlike salivary stones, salivary duct stenosis affect primarily the parotid gland. 70 to 75% of the stenosis are located in the parotids, and 25 to 30% will be affecting the submandibular glands. The stenosis can be associated with stones at the same time in about 15% of the cases in the parotid, and a small percentage in the cases of the submandibular, somewhere between 2 and 5%. These stenosis in both glands, the parotid and the submandibular, would invariably be associated with chronic inflammatory changes, not only in the duct system, but also in the salivary glands parenchyma. What causes salivary duct stenosis? There are some etiological factors and some association with other conditions or diseases. Allergy and autoimmune disorders came first, with somewhere around 30 or 15% for both conditions, followed by stones, which can cause stenosis in somewhere around 15% of the cases. Prior surgery in the duct would cause also strictures in about 13.8%. Prior irradiation to salivary glands or field of irradiation including salivary glands in about 5% of the cases, and fibrosis due to a dental prosthesis in somewhere around 1.5%, and other rare conditions including anatomical variations in the duct system or injury like trauma, or rarely other diseases, systemic or local diseases including the recurrent parotitis in the adult and the pediatric forms, and IgG4 associated disease. The pathogenesis starts with a reduced salivary flow and ascending salivary duct infection from the oral cavity, the formation of mucus or even fibrinous plaques in the duct system, followed by strictures or stenosis, and then chronic or recurrent inflammation of the glands, be it the parotid or other major salivary glands. The diagnosis rests primarily on the presentation of recurrent symptoms of painful swelling of the involved salivary gland, particularly at meal time, and from time to time acute inflammation of the gland. The diagnosis can be confirmed by ultrasound, which is the first line in the investigations, or magnetic resonance sialography, which would show the entire duct system, or conventional sialography as the basic imaging modalities. But of course, sialoendoscopy could also establish the diagnosis and be instrumental in the treatment. The diagnostic accuracy of ultrasound scans in salivary stones is very high, including its sensitivity, specificity, positive and negative predictive values, and accuracy. They are all in the area of 93 to 96%. But that, of course, depends on the consistency of the stone, and provided the size of the stone is more than 2 millimeters. The stone itself would show as an hyperechoic shadow in here with multiple echoes from it. This is a stone in the duct of the submandibular gland. But there will also be other information about the gland itself. It is usually hypoechoic in case of a stone in its duct, that can change to slightly hyperechoic after removing the stone. The ducts would be dilated, and if the ducts are not fully dilated, they can be encouraged by some secretagogues like citric acid or lemon juice, and this would show a full dilatation of the duct in case of a stone that is not showing directly. In this scan, you could see two submandibular duct stones. In there, you could see also a dilated submandibular duct, and you could see a hypoechoic submandibular gland. After surgery, by a few months, this hypoechoic submandibular gland has recovered, and would now give slightly hyperecho on the scan. And of course, the duct itself is now not fully dilated, and you couldn't see any traces of the stones. Conventional sialography, when a radiopaque dye is injected through the duct papilla into the duct system, would provide information about the whole duct system up to a level of obstruction. Anything distal to this would not show up in the scan, and the information on the gland itself would be indirect in case the dye does not pass to the intraglandular branches. The irregularities in the duct would usually reflect an inflammatory process, some fibrosis following this. A filling defect could either be a stone or a stricture or a web or even a mucus plug, and it may show some dilatation of the ducts like Sialectasis. It should not be used during an acute inflammatory episode, as this may push the inflammatory exudate further into the gland itself. It also can cause bleeding during the cannulation or even trauma to the papilla or the ducts, and sometimes rupture of the duct if undue pressure is used to push the dye into it. It may not be successful in about 10% of the cases and requires good cooperation from the patient. Due to all these reasons, the application of conventional cyrography is no longer a first choice. The first choice is the ultrasound scans, followed by MR, magnetic resonance sialography. Formal sialography, by injecting a radio-opaque material in the salivary gland duct system, is still available, but it's not very widely used because it is technically difficult. It can fail in up to 15% of the cases, and it is invasive. It can also provoke some inflammatory process in the gland and can cause injury to the ostium, the papilla, and some scarring. Rather than the formal sialography, magnetic resonance sialography is a much better option. It's a non-invasive technique using the highly T2 weighted MRI techniques. Without requiring any duct cannulation or contrast medium, it can show the saliva itself inside the duct system, and this very clear maximum intensity projection can give very valuable information about any strictures, any stones, or any plugs inside the duct system. It has a quite high specificity but lesser sensitivity. The magnetic resonance imaging sialography would not only confirm a diagnosis of a stenosis or a stone or a plug, it will also characterize that filling defect in terms of its length and the degree of the obstruction. Such information are useful in the grading of the stenosis of the duct system. It can also quantify any widening, any Sialectasis in the duct system, and give valuable information about the parenchyma of the gland itself, not only the ducts. And the MRI sialography will also provide information helpful in classification of the types of the duct stenosis. We shall see different types here, and later we shall see also different grades. The different types can be either a focal stenosis or stricture, or a segment, a longer stenosis or stricture, or multiple types in C, several strictures or several segmental stenosis, or even a diffuse type of stenosis affecting the entire or the majority of the duct system in type D. And then came the endoscopy, which allows direct visualization of the ductal system, and not only the diagnosis of strictures, but also characterizing that strictures in terms of the luminal narrowing. This would have allowed grading of the stenosis by the use of cystoscopes into grade 1 when there is only some inflammation causing stricture of the duct, or grade 2 when this inflammatory process had caused a fibrous or a web-like stenosis, but the lumen is narrowed less than 50%, or in grade 3 the lumen has narrowed more than 50% with the fibrous scar. The endoscopy allows differentiation between an inflammatory narrowing and a fibrous narrowing after the inflammation had caused enough mature fibrosis. And combining the magnetic resonance sialography and endoscopy had allowed precision in the grading of the stenosis. These are different grades, not types of stenosis, by using both techniques. In grade 1, there is an inflammatory process in the saloscope and a mild stricture, not without any dilatation of the duct system, usually because of the inflammatory process has not yet matured. In grade 2, there would be dilatation of the duct system, but the extent of the stenosis would be less than 50% of the lumen, and in type 3 there would be marked dilatation on the MRI, and the extent of the stenosis on the endoscopy is more than 50% of the lumen. The salivary duct strictures, unlike salivary stones, affect primarily the parotid glands. Most of the stenosis are found in the parotid glands rather than the submandibular. Somewhere just less than 30% of recurrent parotid swellings are caused by strictures rather than stones. A much less percentage, around 3%, would cause recurrent submandibular swellings. Nearly 2/3 of these stenoses are just focal point grade 1 strictures that can be dilated using saloscopes and balloons or different ways of dilating strictures. Longer segments or multiple segments are seen in less than 1/3 of the cases. The strictures can be either dilated using the saloscope, or it can be dilated under fluoroscopic control while using conventional sialography and balloon dilatation. There are 3 groups of management policies in salivary duct stenosis. For the very mild, and when the gland is starting to atrophy, there is the group of conservative management. For the very resistant or the very severe symptoms in which treatment fails, there is the ablative process and gland resection, and in between there are interventional procedures, either using the sialoscope or open duct incision through the oral mucosa in the case of submandibular gland, or externally in the case of the parotid. In patients who don't have much symptoms or far in between symptoms, or in patients in whom the gland is starting to atrophy, conservative management can be helpful. This includes gland massage, anti-inflammatory treatment, including steroids and antibiotics when there is an acute inflammation of the gland. In the era before the sialoscope and the minimal invasive therapy, the failure rate of this conservative management was about 50%, and in that case, most of the glands had to be removed. With the introduction of the minimally invasive procedures, now most of the glands can be preserved. Only a minority of the gland, less than 10%, would be removed. Most of the glands would be with stenosis would be treated either with the salendoscope or with ductal incision if this is possible. Before the availability of sialoendoscopy, sialography-guided balloon dilatation was used in the management of duct strictures and stenosis under vision with balloons. This was helpful in just more than half of the cases, providing either complete opening or partial opening in more than half of the cases, but in about 1/3 of the cases there was no response at all. These are not too bad results, but there were other disadvantages, including the failure to see the duct system directly. You are only seeing it through the imaging of the sialography, and also the radiation exposure and the risk of reaction to the contrast medium, or a risk of rupture to the gland during instrumentation. After sialoendoscopy was introduced, the sialography-guided balloon dilatation is no longer a first-choice management plan. Sialoendoscopy allows direct visualization of a stenotic segment or point, and the use of balloons or instruments like boginage or forceps or even laser to dilate that segment. followed by steroid instillation directly into the duct system. There is a good evidence that patients who received the intraductal steroids had a significant better outcome than those who don't. And then a stent can be applied and inserted into the stenotic part in some patients to prevent restenosis. And the patients would usually be followed up for 3 months or so to check for any change in the symptoms and to deal with any possible complications. Management of the duct stenosis in Wharton's duct and Stenson's duct can be different due to the anatomical factors. In Wharton's duct, most of the duct runs submucosally in the oral cavity, and incision and open incision through the oral mucosa is used in most of the cases. The Sialectasis guided therapy is used when the stenosis is closer to the gland or in the hilum of the gland or closer to the proximal third of the duct system. The treatment options includes ductal incision procedure in most of the cases if the duct can be accessed through the oral cavity, or interventional salivary with balloons in about 80% of the cases, and bougainage or laser in 12% of the cases. The success rate are quite high in the area of 80 to 100%, with a complete resolution in a less percentage, about 50 to 80%, and preservation of the gland in more than 90% of the cases. In Wharton's duct, just irrigation through a Sialectasis guided therapy with a solution containing steroids can be sufficient in 12% of the cases. Actual use of Sialoscope with balloons and lasers is only required in about a fourth of the cases, mostly cases close to the gland itself in the proximal part or the hilar part of the duct. The patient who had endoscopic treatment are mostly free of symptoms in about more than 90% of the cases. Those who kept their glands had no symptoms. After 4 years, only about 3% of the patients who had preserved glands had persistent symptoms after a follow-up period of 4 years. In summary, the most important factor in determining the treatment choice in Wharton's duct stenosis is the location of the stenosis. If it is in the distal part of the duct, the part of the duct that can be accessed through the oral cavity, then transoral duct surgery with incision and marsupialization, creating a new opening of the submandibular duct into the oral cavity, is the easiest way of treatment, although it provides success rate in the area of 60% only. But the prerequisite for this choice is that the marsupialization of and creation of the new ostium can be achieved through the oral cavity. If the stenosis is distal to this, closer to the gland itself or in the hilar area, then Sialectasis will be required for opening and dilatation in an attempt to preserve the gland. The duct incision procedure, when the obstruction can be identified by a Sialectasis in the submucosal part of the duct prior to the papilla, will be approached perorally. The Sialectasis will localize exactly where the stricture is or even the stone, and an incision of about 2 centimeters above this into the oral mucosa is carried out, followed by identification of the lingual nerve and protection of it, incision of the duct in the stenotic area, and marsupialization to create a new opening into the oral mucosa, or scooping of the intraductal stone and repair of the duct sometimes can be carried out, and followed by stenting of the duct for a few weeks to prevent re-stenosis. The success rate for this type of procedure is usually in the area between 60 and 70% in long-term follow-up patients. We now move to the treatment of stenosis in the Stensen's duct, which is more difficult than managing Wharton's duct obstruction. Conservative management again should be tried first, but more than 50% of the cases would fail, and a more invasive method would be required, such as extended papillotomy, incision of the narrowed papilla if that's the cause of the obstruction, or distal duct incision, and or repair of the duct itself, salivary using a vein insertion of a vein patch, or even duct ligation as an ablative procedure. The success rate for parotid duct stenosis by intervention of this sort will be in the area between 50 and 70%. The use of endoscopy guided therapy improved success rates substantially, and also the rate of gland preservation. There was less and less need to ablate the parotid gland itself. This would usually entail the sialoscopy guided therapy, cannulation of the duct and irrigation with steroids and balloon dilatation, sometimes opening up of the stenotic segment, and repair of the duct using things like a vein graft or combined transcutaneous and endoscopic approach, as we'll explain in a second, and stenting of the repaired duct with administration of cortisone and antibiotics through it during the healing phase. When there is a parotid duct stricture that cannot be accessed perorally, or when the stricture is close to the gland or inside the parotid gland itself, it can be approached through a combined sala endoscopy and an external parotid surgery procedure. A limited parotid incision is carried out with exposure of the gland and using a facial nerve monitoring dissection to identify the parotid duct. Sala endoscope would be introduced through the duct papilla, and it would identify the place of the stricture or the stone, whether in the gland itself or close to it, and then an incision on the duct is carried out to scoop the stone or to remove the stenotic segment. This can be either repaired primarily or with the use of a vein graft using 7/0 or 8/0 Prolene sutures, followed by stenting of the duct and closure of the wound. When all the treatment options for salivary duct stenosis or obstructive duct lesions fail and the patients remain symptomatic, then ablative procedures should be considered, either surgical removal of the gland or ligation of its duct, or even inducing reduced flow of saliva through the gland by Botox injection. Duct ligation used to be successful in about 50% of the cases only, and is therefore not a preferred option. Removal of the gland is the last choice if all relevant treatment options have been tried and the symptoms persist. Then the gland should be removed surgically. In persistent obstructive symptoms in patients in whom other treatment modalities fail, Botox parenchymal injection in a parotid gland is sometimes the technique of choice. It would reduce the secretory capacity of the gland while avoiding xerostomia, basically because the basal secretory activity of the gland is maintained through the adrenergic pathway of salivary secretion, and the Botox would only block the cholinergic pathway. It can be successfully used to treat the obstructive symptoms resistant to treatment, or things like sialoceles or chronic recurrent parotitis. It's the most frequently used botulinum toxin is type A, and it's injected in the parotid gland using an ultrasound Doppler control to avoid intravascular injection of the toxin. The rare complications would be a transient paresis of some of the facial nerve branches, usually the one to the upper lip, or numbness of the upper cheek. But the major limitation of this technique is that it is only temporary and provide relatively brief duration of symptom-free for about 3 or 4 months. It can be repeated, of course, after a few months several times to keep symptoms under control. By far, the commonest cause for salivary duct obstruction is Sialolithiasis, salivary duct stones. They affect submandibular gland in most cases. More than 80% of them would be in the submandibular gland, 15% in the parotid, and less than 5% in the sublingual gland. Some of the minor salivary glands can also be affected by stones, particularly those in the upper lip. The stones in the submandibular glands would be located mostly in the distal duct, more than 2/3 of them, and only about 13% in the hilum of the submandibular. In the parotid gland, about 1/4 of the stones would be located in the intraparenchymal parts of the duct system. Some forms of imaging would be required to differentiate between the different types of obstructive sialodenitis. Plain radiographs are not particularly helpful because at least 20 to 30% of the stones would not show on plain X-rays, particularly 90% of parotid glands that are radiolucent. Most of the submandibular stones are radio-opaque, but again it depends on the amount of calcification of the stone in order to show it. In this orthopantograph you could see a very faint shadow of a submandibular stone projected against the ramus of the mandible. One particular form of plain X-rays that can be useful is the occlusal films that can be used to show stones in submandibular duct, particularly around the papilla, that are hard to identify by ultrasonography. Salivary stones are discussed in a separate presentation. The video link you will find at the end of this presentation. But in generally speaking, the management of salivary duct stones include more than 8 different options. They depend very much on several factors, including which major salivary gland, the size of the stone ranging from less than 2 millimeters to more than 10 millimeters, and its location in the duct, whether it is very distal or very proximal inside the parenchyma of the major gland itself, and whether it is mobile or attached to the duct wall, and whether there is any associated problems in the ducts like a stenosis or a kink or sharp angles. The treatment options will then vary according to these factors and include manual expression of a stone presenting in the papilla through a transoral approach, or using cystoscopes to retrieve a small stone from the duct, or by a use of a basket retrieval under radiological control, or use of shock waves to fragment the stone into smaller sizes that can be retrieved either by cystoscope or under radiological control, or combined endoscopic and transoral duct incisions, particularly in the submandibular gland, or even removal of the whole gland for very big stones. Recurrent parotitis is another salivary gland pathology affecting duct system and other parts of major salivary gland. It again has a separate presentation. The video link you will find at the end of the presentation. But I'll touch on several points in the juvenile recurrent parotitis duct pathology in this presentation. Basically, the pathology involved here is a duct dilatation and also multiple duct strictures in areas where there is extensive fibrosis and acinar cells atrophy, together with interstitial fibrosis of the gland parenchyma and periductal inflammatory infiltrate. This is an inflammatory disorder of the salivary gland, affecting almost always, but not exclusively, the parotid glands. It's of a non-obstructive nature. The ducts are actually widened rather than narrowed or blocked. It affects children up to the age of 16. There is a somewhat different version of the disease that affects adults. It's usually unilateral, affecting one parotid at a time, but occasionally in less than a fourth of the cases it may affect the two glands. And it is recurrent, then children would have 2 or more episodes before puberty, sometimes up to 10 episodes in a year or more. The onset of the inflammatory episode is usually sudden, with a rapid increase in the size of the affected parotid gland, usually on one side. There would be an overlying erythema of the skin and pain in the parotid gland, and there would also be fever. If the gland is gently pressed or massaged, a whitish discharge could be expressed from the parotid papilla. The parotid papilla itself would always be hyperemic. The acute episode would last anything between 3 and 7 days, but this can extend up to 3 weeks in some severe forms. Often, the first episode of the parotitis is attributed to mumps before the true nature of the disease is diagnosed. In areas where there is widespread vaccination against measles, mumps, and rubella, the MMR vaccine, the incidence of mumps is now next to 0. It's highly unlikely that the children will be affected by mumps after 2 doses of the triple vaccine. How the disease develops? The most significant element in the development of the disease is the dilatation of the parotid duct. This Sialectasis, perhaps combined with decreased salivary production as well, would favor ascending infection of the parotid gland through the oral cavity. This would cause partial obstruction of the ducts with mucus plugs sometimes, or debris or inflammatory exudate, and this would result in further dilatation due to the kinking or the partial obstruction of the duct. Also, there would be some distortion of the duct itself, as you could see, and with an inflamed areas and fibrous healing of these inflamed areas, some strictures could also be noted. Despite the generalized dilatation, there would be localized strictures in many areas, giving the duct this beaded-like appearance. Then metaplasia of the covering epithelium would cause excess mucus production and mucus plugs, and this would cause further reduction in salivary flow rate and predispose to recurrent infections. To confirm the diagnosis of juvenile recurrent parotitis, ultrasound scan is essential. This is the #1 imaging modality chosen in this condition because it's non-invasive, it's cost-effective, and quick imaging modality. It's useful in the diagnosis and also for follow-up purposes. The basic criteria are enlarged gland and heterogeneous echo. enlarged and heterogeneous echo with multiple areas of hypoechoic, always millimeters, like 1 or 2 millimeters in diameter, surrounded by these areas of lymphocytic infiltration. So these are the basic features: multiple hypoechoic areas of millimeters diameter, surrounded by areas that resembles the periductal lymphatic infiltration. Parotid sialography entails the installation of a radio-opaque material into the duct system, usually iodine-based. This would give a very clear image about the duct system, including its caliber and its arborization up to its very peripheral ducts. The features in juvenile recurrent parotitis are basically a dilatation of the distal duct that extends either to the two-thirds or the whole of the gland, depending on the severity of the condition. This dilatation can also be associated paradoxically with some narrowing, some narrow segments of stenoses that are usually due to the inflammatory process and the healing with scar tissue. There may be also kinking of the duct system and distortion of the distal duct. These are the characteristic features of the parotid sialogram in juvenile recurrent parotitis, and this imaging modality can also help in classifying the condition to mild, moderate, or severe according to the extent of the disease into the 1/3, 2/3, or whole of the parotid gland. MRI scans and MR sialography are usually reserved for some special cases. It shows the basic pathology again, with some areas of Sialectasis surrounded by the lymphocytic infiltration and diffuse enlargement of the salivary gland itself. Parotid sialoendoscopy is useful not only in confirming the diagnosis, but mainly for the management of the condition. It shows some features of the disease, including the dilatation of some segments of the distal ducts and localized stenosis due to fibrosis in some parts, multiple stenosis in some parts of the dilated ducts. You can see mucus plugs inside the ducts and scar tissue in the mucosa, but the characteristic appearance would be this whitish lining of the inside of the duct due to the squamous metaplasia of the repeatedly inflamed duct surface, and you can no longer see through the thin epithelium the blood vessels underlying the duct lining. This whitish appearance of the duct is considered by some a characteristic feature of the disease. It's useful in confirming the diagnosis, but similar features can also be seen in other autoimmune conditions, including Sjogren's disease. And now to the management of juvenile recurrent parotitis, and these include a long list of suggested therapies, including symptomatic treatment with painkillers and antibiotics, analgesics, intraductal injection of saline with or without dilatation of the duct, or installing antibiotics or antiseptic solutions, or steroids. Also sialography with high concentration of iodine, or sialoendoscopy with duct dilatation with balloons in the multiple stenotic segments. Other forms of treatment used in the past, like ligation of the duct or injecting a sclerosing agent in it, radiation of the parotid, or even parotoidectomy or tympanic neurectomy have fallen out of favor. Most of these other forms of treatment are no longer used. Adult version of recurrent parotitis, RPA, is usually bilateral, but at times can be unilateral. It can arise de novo in adult life or can be a progression from juvenile recurrent parotitis. The inflammatory process would cause progressive gland parenchymal degeneration, sometimes associated with acute episodes, during which pus can be seen coming out from the Stensen's duct orifice. The histopathological features are duct dilatation, sometimes with some metaplasia of the duct cells, and acinar cell atrophy, and interstitial parenchymal fibrosis. The fibrosis is mostly periductal due to the inflammatory infiltrate, which is predominantly lymphocytes, sometimes plasma cells and eosinophils as well. Sialography can be useful in establishing the diagnosis of recurrent parotitis in adults. It shows this characteristic sausaging. This is due to the Sialectasis, the significant dilatation of the duct system associated with occasional fibrosis at certain segments due to scar tissue formation or the weakening of the duct wall. CT scans of patients with recurrent parotitis in adults would usually show bilateral parotid gland increased density due to the inflammatory infiltration that displaces the radiolucent fat content of the parotid. The management includes treating the acute infection episodes, and for the chronic recurrent form, patients who have mild complaints may be helped with sialogogues and parotid gland massage. Sialogogues would increase the flow of saliva in the duct system and reduce the accumulation of the debris and mucus plugs. The same effect could be obtained by massaging the glands to flush out any obstruction to the duct system. Steroids and antibiotics can also be used, particularly during the acute episodes, and sialoendoscopy, if available, would be helpful in unclogging any duct obstruction, sucking out mucus plugs and removing any debris. In the very severe forms or the intractable forms, the treatment options would include trying to induce fibrosis of the duct system by intraductal injection of agents like methyl violet, which would cause an inflammatory response followed by fibrosis and glandular atrophy, or even ligation of the main duct to induce glandular atrophy as well. Occasionally, subtotal or even total gland excision may be required in very severe forms. We now move to another group of disorders affecting the duct system, including cysts, papillomas, and carcinomas arising from the duct cell wall. These, starting with the duct cysts, these are simple cysts arising from mucosa lining the duct wall. They are true simple cysts, retention cysts due to the blockage of the mucus inside an epithelial lining uniocular cysts. They are not mucus extravasation. They are about 1.5% of all salivary gland disease and contain either a thin serous fluid or mucoid material inside and lined by cuboidal, columnar, or squamous epithelium. Sometimes there may be onchocystic metaplasia, particularly in the elder individuals, but they are not associated with any lymphoid infiltration, and what they can cause is either a blockage of a small duct or a superimposed infection in the area, or sometimes in long-standing cysts they can lead to stone formation due to the saliva flow reduction in the area of the cyst. The management is surgical excision. Recurrences are rare and result from incomplete excision. Duct papilloma are a group of benign papillary neoplasm of the excretory ducts. with three major subtypes: intraductal papilloma or inverted ductal papilloma or Sialectasis papilliferum. They are very rare. Things like 40 cases were only reported for the intraductal papilloma, which is basically a tumor of the minor salivary gland duct origin, very rarely affecting the major glands, affecting mostly the fifth or the sixth decade with no gender predilection. It forms a painless submucosal mass. The inverted duct papilloma is also very rare, with only about 35 cases reported. They are again a tumor of a minor salivary gland origin, particularly in the lip and the buccal mucosa, and also present as a painless submucosal mass. They form a well-circumscribed mass, much like the intraductal papilloma. All the ductal papilloma can be mistaken for other papillary salivary gland tumors, and the differential diagnoses include cystoadenomas and cystoadenocarcinomas. Sialectasis papilliferum is also very rare. Around 50 cases were reported. They also occur in the fifth or the sixth decade, but they are most frequent on the palate, and rather than present as a submucosal mass, they present as a granular papillary mass. All these tumors, all these papillomatous, their treatment is surgical excision, and this is usually curative, the recurrences being related to incomplete removal. Some very rare cases of malignant intraductal papillomas transformation into a malignant Sialectasis papilliferum are described. And salivary duct carcinoma, which forms about 10% of all the salivary gland malignancies and affect mostly older men, particularly in the parotid gland. They may arise de novo or secondary to a pre-existing pleomorphic adenoma. In about 20% of the cases, they will be malignancy X pleomorphic adenoma. They are aggressive. They have high-grade aggressive behavior with a tendency to regional lymph nodes invasion and distant metastasis. In the parotid, they affect the facial nerve in about a third of the cases. The common sites for distant metastasis are the bones and the lungs. The management for these aggressive high-grade tumors is radical surgery, either parotitis total or submandibular sialenectomy, and ipsilateral neck dissection, together with post-operative adjuvant radiochemotherapy. And finally, we'll move to pathological changes affecting the function of salivary duct cells. These are functional disorders of the cells associated with systemic disease. It can be diagnosed by the analysis of the secreted saliva. The pathological changes in the saliva electrolytes in particular would reflect the condition affecting the duct cells. The initial fluid, the initial saliva secreted by the acini, are pushed into the ductal system. You have three types of duct cells, three types of duct systems: the intercalated duct system initially, followed by the striated ducts with this basal striation in the basal part full of mitochondria, and then the final secretory duct at the end. As the fluid passes through the duct system, it becomes progressively less isotonic. It becomes eventually hypotonic. Most of the sodium and the chloride are absorbed in the ducts, and more potassium and bicarbonate are added to the saliva, and some protein from the intercalated part of the duct system. So the final saliva secreted from the excretory duct would be different from the isotonic saliva secreted in the acini. In the basal saliva, without stimulation, without the resting saliva, saliva would be hypotonic, slightly alkaline due to the bicarbonate in the saliva and will be rich in protein and the potassium secreted through the duct system. When the salivary glands are stimulated, the flow of the saliva is more rapid and there will be less time for the ductal cells to absorb the sodium and the chloride or excrete potassium and bicarbonate. Therefore, the fluid would have higher concentration of sodium and chloride and a lower concentration of potassium and also bicarbonate, and it will become less hypotonic than the resting or the basal saliva. Pathologic changes in saliva electrolytes would usually reflect a defect in the duct cells of the salivary secretory unit. For example, in Sjogren's syndrome, where duct cells are damaged first, you would find a raised level of sodium and chloride ions. These are the ions that are meant to be absorbed by a functioning tubular ductal cells. The same would be expected with radiation damage induced by radiotherapy in the treatment of cancer. You would find in the saliva of parotid raised sodium and chloride levels in addition to calcium and magnesium. This is again due to the damage of the duct cells. You would also find depression in the sodium levels in hypertension and raised potassium levels with alcoholic cirrhosis. In hyperparathyroidism, there will be raised calcium levels. In diabetes, there will be raised calcium levels as well. In chronic pancreatitis, the level of the bicarbonate will be depressed. Some psychiatric illness, there will be some raised levels of the sodium. Some indices, clinically diagnostic indices, could be obtained for cystic fibrosis, aldosteronism, and digitalis intoxication by combining the levels of different electrolytes together. Cystic fibrosis is an autosomal recessive genetic condition affecting 1 in 3,000 newborns in Northern Europe. The main defect would be a disorder in the regulation of chloride ion transport across cell membranes. The net effect of this would be the formation of secretions from all exocrine glands, secretion of increased viscosity due to increase in total saliva protein and in calcium content. And although the volume of the total saliva production may not be too disturbed, there will be significant changes in the salivary chemistry, marked by a dramatic elevation in salivary proteins and calcium concentrations. The net effect of this would be predisposition to salivary duct blockage and stone formation. Multiple small stones could form from minor salivary glands at the edges around the gingival margins, for example, multiple small stones. By this, we come to the end of this presentation on salivary duct system and salivary duct cells disorders. Assalamu alaikum.